Bienvenidos a una nueva edición de Tópicos Selectos de Cardiología, un proyecto en colaboración con la Revista Colombiana de Cardiología. El tópico que vamos a revisar hoy es acerca del tratamiento intervencionista del embolismo pulmonar. Es una charla muy interesante que fue dada por el doctor Sahil Parikh de Colombiana University, un compañero de nosotros, donde revisa toda la gama de tratamiento del embolismo pulmonar, desde la parte del diagnóstico, tratamiento farmacológico e intervencionista de esta condición tan común en nuestros pacientes. Es un tópico muy importante que cubre muchos aspectos del embolismo pulmonar y que no es solamente importante desde el punto de vista de intervencionismo, pero también médico y clínico en las unidades de cuidado intensivo. De verdad que espero que disfruten esta revisión, una revisión muy detallada del estado del arte de este campo, y de verdad que espero que la disfruten y nos vemos de nuevo en un mes en un nuevo capítulo de Tópicos Selectos de Cardiología.
Topic for the morning and really for the course before we go to the case reviews is to talk about pulmonary embolism therapy and what you need to know. So now, in contradistinction to carotid disease, the growth of venous procedures and thromboembolic procedures has been explosive over the last decade. There has been a lot of interest in the area, and we as interventional cardiologists, particularly those who are in large health systems, are seeing an explosion of these patients finally being brought to our attention, whereas they used to reside often in the medical intensive care unit or other places in the hospital. These complex VTE patients are now coming to us. So from a core curriculum of knowledge, I think obviously it's important to understand the genesis of venous thrombosis, which is really from the classical Virchow's triad of stasis, venous injury, and hypercoagulability. The reason it's an important disease for us as interventional cardiologists to know about is that it's highly lethal, up to 10% case fatality within an hour in massive PE. And untreated pulmonary embolism has a mortality rate of approximately 30%, with early mortality linked closely to the probability of a recurrent PE. It's usually the second embolus that is the lethal one, with very high case fatality rates in recurrence. The 2016 statistics for VTE suggest that there's now almost as many pulmonary emboli deaths as strokes. And so I'd said in the last talk that the stroke was number 3. Well, PE is now giving stroke a run for its money as a number 3 cardiovascular morbidity and mortality disease entity. And it's interesting, either this is a diagnosis bias and an ascertainment bias, but we're seeing a greater number of venous thromboembolic events per 100,000 patient years in the United States currently. So this is a growing problem, and it's a big problem financially, and consequently it's caught the attention of CMS and the government third-party payers. Estimated $15 billion of expenditure on pulmonary embolism in 2016 dollars. Unfortunately, the awareness of DVT and PE is low compared to other medical illnesses as shown here. And so there's a problem and a mismatch between the public awareness and the clinical problem. So what's the pathophysiology of severe pulmonary embolism? Typically, when you have obstruction of the pulmonary vasculature of greater than 75%, the RV must generate systolic pressures greater than 50 millimeters of mercury with mean PA pressures of almost 40 millimeters of mercury to maintain forward cardiac output. An untrained RV is rarely able to generate this kind of pressure, and this is the mechanism for abrupt pump failure in the setting of massive pulmonary embolism. When we look at these patients and think about them, we sort of put them in 3 different buckets. There's the so-called non-massive or non-life-threatening PEs generally who are thought to be low risk for mortality. There's a so-called submassive, which is probably an ill-construed term that we use to really look at patients of so-called intermediate risk, and we'll talk about that in some detail. And then there's the massive patient with hemodynamic derangements that is a high-risk patient for mortality. The Europeans have, I think, simplified this very easily, and I think this is a good way to think about it. If you have an acute PE and the patient has shock or hypotension, they're high risk. If they don't, they're not high risk, which I think is even an interventional cardiologist can understand. And the more nuanced and probably the most important take-home from this talk for you is the current way of thinking about pulmonary embolism is to think about them in terms of mortality risk as a function of a few different parameters. So patients with shock or hypotension are clearly in the high-risk group. Patients with risk stratification scores called the Pulmonary Embolism Symptom Index, or PESI score, that's greater than 1, are also in that high-risk category. And then if they have signs of RV dysfunction or elevated cardiobiomarkers, those may also be signs of high risk. The challenge is in those patients who are in the intermediate risk category who don't have shock or hypotension, but do have evidence of some of these other high-risk features. And that's where most of the debate and lack of agreement is in the field. And then there's the clearly low-risk patients who have none of the above, who are low risk. And so if you look at the European guidelines, which I think are worth a read, they really stratify patients with PE first based on shock or hypotension, and the ones who do have shock or hypotension go down the high-risk PE algorithm and are candidates for catheter-based or surgical embolectomy, and we'll talk about that since as interventionalists, that's where we've been engaged in the field. Then there's the majority of patients who have low risk and are able for ambulatory discharge, and this is what's going to show up on the cardiology boards for those who haven't taken it yet, and so we'll go over it. And then there's the folks in between who have some high-risk features, but not all of the high-risk features, including overt shock. So let's look at this a little bit more. So what's the PESI index? It's basically a risk stratification algorithm that was originally quite complicated and included all of these different variables. The simplified version, which I'll show you on the next slide, is probably worth remembering. And this includes patients with age greater than 80, concomitant malignancy, heart failure or pulmonary disease, tachycardia, hypotension less than 100 millimeters of mercury, and desaturation. Any one of these confers a higher risk of mortality, and probably if you identify any of these problems in a patient hospitalized with pulmonary embolism, they should probably be in a higher level of care than in a standard ward or a telemetry floor. So what about the outpatient treatment of PE? Let's talk about those patients briefly since it'll show up on your boards. This is one of several examples of the use of a novel oral anticoagulant, rivaroxaban, for the ambulatory management of DVT and PE. This is from the Einstein series of studies. We have all of these different kinds of packs where we can identify these patients in the emergency department and potentially discharge them, and that's the push from our health systems. And those patients who are candidates for outpatient therapy are ones in whom they're hemodynamically stable without desaturation and no other comorbidities that would get them a PE severity index greater than 1. And they should be able to follow up and have normal biomarkers in every case. There's a laundry list of things, though, that make them not good for outpatient therapy. And I've been attending on the wards at Columbia for the first time this past month, and I've been not surprised how often this comes up, that many patients who we'd like to treat as ambulatory patients wind up needing to be admitted because they have one of the routine things or one of these other serious comorbid illnesses. And particularly the psychosocial exclusions, depending upon where you practice, these should be carefully weighed before you consider outpatient therapy of pulmonary embolism especially. If you wanted to dose them with these novel agents, I would remember these numbers. Rivaroxaban is 15 milligrams BID for 3 weeks, followed by 20 milligrams daily. Apixaban is 10 mg BID for 7 days, followed by 5 milligrams BID. Dabigatran is 150 milligrams BID after parenteral treatment in the hospital, and edoxaban is 60 milligrams daily after an initial hospitalization. Edoxaban is the only NOAC that has been studied in patients who had submassive pulmonary embolism, as well as in outpatient or ambulatory DVT and PE. And there's different renal clearances, and I think we're all familiar with these because we treat patients with atrial fibrillation with these agents, but knowing that this is available for our DVT and PE patients is reassuring. Now, there's a lot of controversy about what qualifies as massive and submassive. This is a definition that is in a recent guideline statement from the AHA published in Circulation in 2011. I think the reason it's important to characterize patients as either submassive or massive is because there's such a huge difference in mortality. This is from the ICOPER registry from Sam Goldhaber and Niels Kucher, and you can see that massive pulmonary embolism patients have a mortality of about 50% at 90 days. So it's like cardiogenic shock, right? Even in revascularized patients with cardiogenic shock, their mortalities are upwards of 50%. So one of the biggest characteristics that we look for in these patients is their RV function. And clearly, if you look at registries of these patients after PE, RV dysfunction is a marker of higher risk. Here you can see 13.3% with PE-related mortality at 3 years if there's no resolution of RV dysfunction at discharge, compared to 4.4%. Here's another example from the Brigham and Women's Hospital looking at RV to LV ratios being identified. An RV to LV ratio greater than or equal to 0.9 is a marker of high risk, and this is measured on non-gated CT scans such as those done for pulmonary embolism. And then there's a long-term complication, and a vexing one, which is occurs infrequently but can be life-threatening and devastating, and that's chronic thromboembolic pulmonary hypertension, or CTEPH. And this occurs in 0.5 to 3% of all PE patients, and it's very hard to predict who will develop this and who will not develop this. And it's defined as developing pulmonary hypertension with a mean PA greater than 25 in the setting of a normal wedge and LVDP less than 15 millimeters of mercury. So what do we do with these acute PE patients? The easy ones, the 65% that are ambulatory candidates, will get discharged ideally on a NOAC if that's feasible. But it's the ones in the middle, the intermediate and high-risk patients, that are more complicated. So we have a host of options. This sort of reminds me of the options we have for femoral popliteal disease. There's an alphabet soup of therapies ranging from conservative anticoagulation to the role of IVC filters, which we'll briefly touch on, to thrombolysis or mechanical therapies with or without mechanical circulatory support. How do we decide what to do for these patients? There are some guidelines. This guideline statement from the AHA was published in 2011. The chest guidelines were just re-upped last year. And again, there's the 2014 ESC guidelines and the more recent update of the chest guidelines. For those interested in this, both for your general cardiology practices and for your board preparation, I highly recommend reviewing these guideline statements. So high and intermediate risk patients, what do we do? Here's the meta-analysis data. There's a bunch of trials of fibrinolysis looking at patients with different severities of PE. And when you look at all comers, there isn't a ton of strength to the argument, although it's barely thought to be in favor of thrombolysis for patients with higher or low-risk PE to have thrombolysis. And then to answer this question, I think more definitively, more recently, was the so-called PYTHOS study, taking a look at patients in the absence of hemodynamic collapse who did have RV dysfunction and myocardial injury. This is a sort of intermediate risk patient with RV dysfunction or troponin elevation who were randomized to heparin plus tenecteplase versus heparin placebo, followed up with antithrombin therapy overlapping with vitamin K antagonists, looked at for primary and secondary outcomes at 7, 30, and 180 days. And when you look at these patients, the so-called moderate or submassive pulmonary embolism patients or intermediate risk patients, all-cause mortality or hemodynamic collapse within 7 days, those patients with thrombolysis had a better outcome as a primary outcome. But despite these studies, these are the latest guidelines, and this might be new to some of you. So in 2016, this is from the chest guideline update. Patients with acute PE associated with hypotension who do not have a high bleeding risk, they recommend, the United States chest guidelines recommend systemically administered thrombolysis. In patients with PE not associated with hypotension, we recommend against thrombolysis. In patients with acute PE who deteriorate after starting anticoagulant therapy but have yet to develop hypotension and who have a low bleeding risk, we suggest systemically administered thrombolysis over no such therapy. So to sort of summarize, for massive patients, there's some support for the use of thrombolysis. For submassive patients with low bleeding risk, there's less enthusiasm, and there's no indication to use it in patients who are low risk. And the reason that everybody's concerned about the risk is hemorrhage, specifically intracranial life-threatening bleeding. And even in the PYTHO trial, which I demonstrated earlier, the results, there was a 2% life-threatening intracranial hemorrhage rate, which is what gives everybody pause about the administration of thrombolytics. So add to that then the host of therapies we now have with catheter-directed treatment. There's the ability to directly infuse lytic agent into the clot, which is specifically important in the use of fibrin-specific lytics. You can achieve higher local concentrations and potentially even fragment the clot to increase the surface area where your drug is going to do its work. And you may also be able to monitor PA pressures. There's also mechanical thrombectomy approaches that have been around for a long time, some of them, and there's some new approaches which I'll highlight. The most recent thrombolytic therapy with catheter-directed lysis that has gained support with clinical data has been the use of the ECO system, which is an ultrasound-facilitated thrombolysis system where the catheters can be placed directly into the main pulmonary arteries or in branch vessel pulmonary arteries, and low-dose thrombolysis, usually less than 20 milligrams in total, can be administered, roughly 1/5 of the standard dose for IV thrombolysis. There's been a series of registry trials supporting this. Ultima was the first of these trials looking at intermediate-risk PE patients where they randomized 60 patients to either ultrasound-facilitated thrombolysis versus heparin alone, and were able to demonstrate that there was a more rapid improvement of RV to LV ratio compared to heparin alone. There was very little bleeding, so this was then put into a single-arm multi-center study where they evaluated the ecosystem to reverse RV dysfunction, again, RV dysfunction being a surrogate for complications, including mortality, as I showed you earlier. And you can see here that there was a dramatic improvement to RV to LV ratio, which was sustained after 48 hours, as well as the improvement in mean PA pressure in this group of patients. And there was no life-threatening intracranial hemorrhage by cutting in five-fold the overall dose of thrombolysis. There is a safety signal that suggests that this is a safe procedure without mortal risk of life-threatening intracranial hemorrhage. What about suction embolectomy? There's different catheters. This is the AngioDynamics Vortex AngioVac catheter, which is a 25 French device that can be advanced into the pulmonary artery to suck en bloc clot out of the main PAs. These are the kinds of fragments from a case that I had done in Cleveland that suggests that you can get large, even chronic clot out in these patients. There's newer technologies, including the FlowTriever system, which is being used in the United States now. Here's an example of a FlowTriever case where you can see the amount of clot from this multi-disc approach is quite substantial. And then there's the so-called Penumbra Indigo system, which is a vacuum-assisted suction catheter that can potentially help with large clot burdens. The chest guidelines say that in patients with acute PE who are treated with a thrombolytic agent, we suggest systemic thrombolysis over catheter-directed thrombolytic therapy. In patients with PE associated with hypotension who have either high bleeding risk, failed systemic thrombolysis, or shock, then catheter-assisted thrombus removal is recommended over nothing. Not a very ringing endorsement. The European guidelines are a little bit more supportive and recommending thrombolysis or catheter-directed therapy with a Class 2A recommendation in the patients with shock, and it remains catheter-directed treatment may be considered in intermediate-risk patients as a Class 2B recommendation. So there remains a lack of consensus across the continents about how to treat these patients. Surgical therapy, just to be complete, has had significant history. These patients, generally, you can take out large amounts of clot in these patients and have excellent results. Here's a cast of a pulmonary artery circulation from a patient of ours in Cleveland post-operatively. And there's more support for the use of that. So here's a summary of those guidelines, which I just went over. But most importantly, it's reasonable to consider surgical embolectomy in patients in high risk, potentially with adjunctive support, with hemodynamic support such as ECMO, and the use of thrombolytics in patients who are too sick for surgery. What about IVC filters? There's only two real indications: proximal DVT with contraindication to anticoagulation, or PE with contraindication to anticoagulation. You shouldn't just routinely insert them in every patient who has venous thromboembolism. And there are some uncertain indications where I see this being done highly variably across the country. Patients who have poor reserve, in other words, the next PE might get them. People who are going to get thrombolysis with catheter-directed therapy get them as a matter of course, and they're usually retrieved subsequently. And then a lot of patients in our center where we do a high volume of pulmonary thromboendarterectomy surgery get them prophylactically perioperatively. And there's an excellent review of this in JACC Interventions from 2013 that reviews all of the different guidelines from the different societies. The problem with PE in general, and the space is exciting for this reason as well, is that there's few Class 1 recommendations for therapy, and there's very few scenarios where they fit squarely into the guidelines. So there's a lot of arguments for more aggressive therapy and other factors that can affect your strategy. And so to that end, there's been a movement afoot across the country, and I credit Ken Rosenfield and the team at Mass General for really crystallizing this over the last several years, where they have a multidisciplinary approach to PE called the Pulmonary Embolism Response Team. And this is sort of a flow diagram of the MGH PE team as it's constituted currently. And there are algorithms, and this is one from Niels Kucher from Bern, Switzerland, where they have very well algorithmized, if you can say that, ways of looking at patients with PE. Anybody that comes in to their hospital with a pulmonary embolism is put through this algorithm. They're evaluated for biomarkers and RV to LV ratio. If there's any markers of high risk, they get an echo within 90 minutes. If there's overt RV dysfunction, there's an activation of a PERT team, which includes a multidisciplinary specialty group of emergency medicine doctors, angiologists, which are interventionalists, cardiologists, and cardiovascular surgeons, who then decide whether the patient needs further therapy. And this is going on all over the United States. I could show you a similar diagram from our center in New York and other places around the country. And there is a consortium called the PERT Consortium, which is now a nationally present group. Here's the latest map of where PERT centers have started to pop up all over the United States. And so I think this is an area of rapid growth and interest. There's an annual meeting in the fall, and there will be a clinical registry of data that is going to be hopefully the fodder for research in the coming decades. So for those of you interested in this space, particularly the area of mechanical circulatory support and catheter-directed therapies, this is an area of huge growth. So let me summarize by saying that if I was to leave you with anything, it's going to be these European guidelines about how to sort of approach these patients. First, discern whether they have hypotension or overt shock. And if they do not have shock, then really risk stratify them with a PE severity index score and see if there's a potential need for either a higher level of care or potentially even catheter-directed thrombolysis, depending upon your own institutional preferences. This is the kind of stuff that's likely to appear on the boards in the coming years and is going to be an area of great evolution. I'm sure this diagram is going to look very different after we have some more data from these clinical trials.
Espero que hayan disfrutado de este nuevo capítulo de Tópicos Selectos de Cardiología, un proyecto en colaboración espectacular con la Revista Colombiana de Cardiología, y espero verlos el mes que viene.